I want to introduce the moderator, Cara Carter. She works for California Healthcare Foundation. I encourage you to look at her bio and to look at the whole body of work that she has and the work that the California Healthcare Foundation does. Thank you, Cara.
Thank you. All right, good afternoon, everybody. We hit the post-lunch slump. All right, I'm really happy to be here. As Hope said, my name is Cara Carter. I'm the Senior Vice President for Programs at the California Healthcare Foundation. I've done a lot of things professionally in healthcare, and amongst them, like everybody in this room, I'm also a patient. So, funny story from about this time last year. Over the last decade, I've been a patient in lots of different ways. Right? So I've broken many bones, I've had a cancer diagnosis, I've had lots of different interactions with the healthcare system. In my professional life, I found myself just around this time last year spending my days crafting, responding to, working up very detailed information about Medicaid billing and Medicaid financing. And in the evening, I found myself trying to navigate a medical bill that I didn't understand. It was priceless. It was very much a cognitive dissonance moment. So I get this bill. I'd had a surgery. I'd had a small procedure. I'd get this bill. I don't understand it. I call my plan. My plan tells me that it's correct, but they can see that there's a problem, but I have to call my provider because the provider is responsible for the problem. I call the provider. The provider says, absolutely not my problem. Please call the plan back. I say, can you guys get on the phone with each other because I'm 4 hours into this? Absolutely, we cannot, but if you hold, I can try to reach them and we can put ourselves on a three-way call. You can see where this is going. So many hours later, I came to the conclusion that healthcare is too complicated. And that it doesn't need to be, right? I mean, we have built this system collectively. We have constructed the system. This isn't how it has to work. This isn't how it works in other places. We have constructed a system that is built and so tangled in rules and silos and bureaucracy that it fails the people that it's designed to serve. So, it's not just patients that suffer in the system. Let's be honest with ourselves, right? How do providers spend their time? Well, we hope that providers spend their time in patient care, looking you in the eyes when you're in their office, helping you figure out how to navigate the system, conducting procedures when you need them. They do that, but they spend how many hours a week do you work? Most people work maybe 40, maybe 50 in the United States. If you're a healthcare provider, you're spending 15 to 20 hours a week on paperwork. Is that how we want our system to work? Is that how we want our providers to spend their highly qualified, precious time? I mean, I have questions about that. And it's not just providers, right? So if you go and look at a health plan, go work in a health plan, there are armies of people, like armies of people who are there to help navigate this bureaucracy and to help push around all the different pieces of the system that we have built and we have created. And if you're a state regulator or a federal regulator, the system is so complicated that the likelihood that you actually understand what you're regulating and what you're passing laws about, it's actually quite low. So being a person who operates in the system, either professionally or personally, is just unreasonably difficult. So this session, we're going to talk about administrative costs. Before a single dollar is spent in the healthcare system, so before a single patient is seen, or a prescription is written, or a procedure is done, there's a big portion of that dollar that's spent on something that is not patient care, right? In the United States, 25 to 30% of every dollar that we spend goes to administrative costs. Right, that's a lot. It's like about north of $900 billion, almost $1 trillion that we spend moving paper around the system. So what is this? What are these administrative costs? I'm not saying that they're all unnecessary. We'll get into that later, but what are we talking about? It's billing, it's prior authorizations, it's claims processing, it's credentialing, it's marketing, it's IT, it's all the things that happen in the system that aren't delivering care to patients. If you take a step back at the current pace, the way that we are spending money in healthcare, we are like 5 to 6 years off healthcare reaching 20% of gross domestic product in the United States. Right? Think about that. 20% of everything that we produce. Intuitively, we all know that can't be the right answer, right? But if we want to make a difference, if we want to make our reality a different reality, if we want to create a simpler system, a more navigable system, a more affordable system, a more rational system, we're going to have to do something very different. Now, I don't pretend to have the answers to that, so I'm really excited to welcome my fellow panelists here to help us navigate those answers and hear what they have to say. So I'm joined today by Dr. Christine Eibner. Christine is the Principal Senior Economist and the Paul O'Neill Alcoa Chair in Policy Analysis and the Director of Financing and Organizational Programs at RAND Corporation. I'm joined by Nikhil Sawhney, who's the leader of the Center for U.S. Healthcare Improvement and a partner at McKinsey & Company. And I'm joined by Adam Solomon, Dr. Adam Solomon, who's the Regional Medical Officer for California for CareMore Health. And I would be remiss not to name that we were due to be joined by Elizabeth Mitchell, who is the president and CEO of the Purchasers Business Group on Health. And she's asked me to let you all know that she cannot join us because she is currently navigating an innavigable part of our healthcare system on behalf of her family. So really brought home for us how important this conversation is. So with that, I'm going to hand to Christine to set the stage. Thank you.
Thank you, Kara. Thanks, everyone, for being here. So the Institute of Medicine, now the National Academies, in 2009, and then many others subsequent to that, have identified 6 major categories of wasteful spending in the healthcare system. And so I have them listed here in this pie chart. First, we have failures of care delivery, and that's when providers don't use best practices, which can lead to adverse outcomes, mistakes, inappropriate care. Examples include medical errors, hospital-acquired infections, that sort of thing. Failures of care coordination. So I should say the failures of care delivery is about 16%, you can see on that chart. Failures of care coordination are when patients don't get the care that they need in a timely and appropriate way, which can result in avoidable problems like people using the emergency room when something could have been addressed in primary care. We have overtreatment and low-value care. So, that's when a patient gets care that has little or no benefit, such as unnecessary antibiotics, or surgeries when watchful waiting could have been an appropriate treatment. Pricing failure when prices are too high. Fraud and abuse, I think, is fairly self-explanatory. That's, some kind of actual malfeasance in general. And then we have administrative complexity, and that's what we've heard a lot of discussed today: burdensome reporting requirements, complex billing, complex reimbursement, excessive documentation, et cetera. So you can see this pie chart shows sort of the relative importance of those things. 31, administrative complexity and pricing failure stand out as being major contributors here. So in this 2019 study by Will Schrank and colleagues, they estimated that 1/4 of U.S. healthcare spending goes to these kinds of waste. So if we extrapolate that to California, in 2023, California spent about $400 billion. So that would be total on healthcare. So this would be about $102 billion in 2023 going to wasteful spending. To put that in context, the Medicaid budget is larger than that, but what California pays for Medicaid is not because of the federal contribution. So this is more than what the state is spending on Medicaid. This is, there's widespread agreement that this is a problem, but solutions have been elusive, right? So in this 2019 Schrank article that I referred to, in addition to kind of quantifying the amount of waste in the system, the authors also looked at solutions and evidence for, ways to diminish that waste. And looking across all of the studies, all the literature, and scaling this nationally, they found that only about 25% of the waste, the literature pointed to 25% of the waste, there was a solution to address it in the literature, meaning that based on what we knew, you could reduce this by about 25%. So that's not nothing, but that still leaves 75% of this unhelpful spending on the table. And again, to put that into the California context, if we're talking about $100 billion being spent on waste, now we've got it down to $75 billion. That's still way too much. It's about what the state currently does pay on Medicaid. So too much money being spent on waste. Another example of how this has been very difficult and intractable to address has been the CMS Innovation Center. So this is the organization that was put into place with the ACA to try to introduce value-based payment models as a way of reducing cost. And value-based payment models hold promise in terms of reducing wasteful spending because providers will get the same amount regardless of whether these kinds of wasteful incidents occur. So they have, these models in theory should give strong incentives for providers to reduce that sort of waste. And so because of that, CBO at the time the ACA was passed scored value-based payments as a big saver and a big pay for the ACA. However, so that was back in 2010 was when the ACA passed. In 2023, CMMI did a retrospective to sort of assess how effective they had been with these payment models that they rolled out, and whether they did, in fact, reduce spending. And what they found is over the first 10 years since that organization went into effect within CMS, they implemented over 50 models, and of those 50 models, only 4 were qualified to, were successful in terms of saving money without adversely affecting quality. And so only 4 were scaled. So you can see how challenging it is of 10 years, 50 models, and 4 were scaled. And, icing on the cake, I guess, the CBO then revised its estimate of what CMMI was saving the federal government. So again, they scored this as a big pay for going into the ACA. In 2023, they revised their estimate and said, not only did CMMI not save money, but it actually is projected to increase cost over time. So first of all, it's not just one problem, it's many. As we saw on that initial slide, there are 6 different categories of waste, and those are broad categories, and within each of those categories, there are subcategories, so there's a lot going on here, a lot to unpack. We also have multiple actors. So we have providers that may not always be up to date with best practices, patients that may pursue suboptimal treatments. We have insurers who may introduce complex billing requirements. The federal government that, could impose well-intentioned but burdensome quality reporting requirements. And any solution will need to consider all of these factors. And related to that, pushing on just one of these problems might solve some problems but introduce others. So think about billing. Billing is complicated, it's a big pain, it's difficult. But an attempt to streamline billing could solve that problem, but it also could make it more likely that there's going to be erroneous or improper payments, which increases a different type of waste. So you have to think about what you're trading off when you're trying to make these changes. There are also misaligned incentives. So this goes back to the fundamental complexities of the healthcare system. For most goods and services, consumers can spot waste more easily. They can see that an object or a good that they're purchasing has poor quality or that it looks too expensive for what it is. But with healthcare, consumers often pay the same price regardless of what the actual underlying cost is. As I think was mentioned earlier today with cost sharing, it's not always the case that it varies. One provider may be a lot more expensive than the other, and you're still paying $25 copayment. In addition, consumers have difficulty judging quality just because they don't use healthcare services in some cases that frequently, or they lack the information to assess it. We also have the problem that one person's waste is another person's salary. So providers often get paid more if patients use more intensive treatments, which contributes to overtreatment. And there are many, there's entire industries now that are dealing with things like billing and with quality measurement and with utilization review. And reductions in these processes could then affect those jobs. And then finally, we have ineffective solutions that have been offered and tried. So one of the things, in going back to this literature to prepare for this talk, I was looking at that Schrenk article, as I said, and looking at the solutions that they proposed. And among the solutions that were proposed, prior authorization. Well, there's a reason for that, right? Because you're trying to reduce ineffective care by, having a prior authorization review. But at the same time, we know that that is also introducing lots of paperwork and creating a burden that might not be necessary. And the same thing can be said for quality reporting requirements. In most cases, those are well-intentioned. We want to improve quality. That's a good thing. But if the reporting requirements become so burdensome that they, overwhelm providers, and if those metrics are marginally or not really well correlated with quality outcomes or become less correlated over time, then we've introduced something that is, burdensome without adding a lot of value. Okay, so despite all that, I want to end on a note of optimism. So one thing that is, I think, worth pointing out is that healthcare spending as a share of GDP has actually remained remarkably constant. This has been a trend that people have noticed since the passage of the ACA. I'm showing here data since 2018, but it looks pretty similar if you go back to 2014 or so. So we're hovering around 18%. There was a blip in 2020 due to COVID, but otherwise we've been hovering around 18%. Now, to Kara's point earlier, the forecasts are saying that it may go up to 20%, but those are forecasts. So for now, it's been pretty stable. And so there's been some debate in the literature about what has caused this, and I don't think there's like a consensus around why we've seen this. There are a lot of hypotheses that have been put out there and some evidence. It looks like there's a lot of small things happening or different things happening that may have contributed to this. Some have posited there's a technological slowdown. Some have posited that deductibles, copays have gotten so high that that's depressed demand. But a recent Health Affairs article by Sherry Gleed and Brendan Liu looked at this issue using 10 years of data and concluded that to some degree this actually has reflected shifts towards more efficient care delivery. And so some of the things they found in that analysis was substitution from higher cost to lower cost treatments, slower price growth, and also expanded scope of practice for advanced practice clinicians contributing to this slowdown. I think emerging technologies, as we've talked about a lot today, are also a reason for optimism. So telehealth is not exactly a new technology, but its use has been expanded with the COVID-19 pandemic. And it holds potential to both expand access to cost-effective providers and reduce reliance on the emergency room. And then artificial intelligence, of course, also holds a lot of promise here. It could be used to reduce providers' time spent coding and time spent billing. And in some cases, it also may be able to flag medical errors before they happen. Finally, last reason for optimism, there's widespread agreement that waste is a problem, and this is in fact bipartisan agreement. So there's not much that's bipartisan these days, but healthcare waste and the need to reduce waste is bipartisan. So there may be opportunities to implement meaningful policies. Okay, with that, questions later or no? Move on. Okay.
All right, so let me just go back a few slides. So I'm going to share a little bit about the administrative waste specifically. And one of the things that when David Cutler, who I'm a fellow with at the Harvard Economics Department, I saw Berwick's and then Schrank's article said, what actually is administrative spending in the US healthcare system? And why do we spend so much and how much of it could be saved? And much of what I'm about to show you actually to the bipartisan point, we actually testified in front of the Senate Budget Committee last year. And both Democrats and Republicans were very interested in what can we do about what we're spending on administrative cost in the US healthcare system. So I think the first thing we found in our research is there is no one solution. I think we've already hinted at this. There are a lot of little things that we need to do to address the administrative spending cost situation in the United States. And it starts by understanding what it is. I think Kara and Christina both mentioned this was analysis we did, built it bottom up. 2019 dollars is still roughly the same. We spend about $950 billion, 25%. What's important is how does it break up by stakeholder? Because what everyone has to do is different in order to capture the opportunity. So this just shows you how much private payers, your Uniteds, your Aetnas spend, how much hospitals spend, separating out physician groups, also the public payers, that's federal Medicaid, that's Medicare, and then other sites of care. There actually is a lot spent in home health, dental, other areas as the NHE breaks it down. What we did, though, is we took a bunch of P&Ls from hospitals, from private payers, from provider groups, recategorized them, and said, what is actually being spent that is administrative cost? We purposely were very black and white about this. So if you have in the hospital a nurse manager that is taking care of patients on the inpatient floor, but also managing the nurses, we excluded that person. We said we're only going to count truly administrative roles and then estimate what they're doing. And we broke it into these 5 buckets. So first is the financial transactions ecosystem, as Kara was talking about. That's claims, that's billing, that's processing what someone receives for care and then making sure they get paid. 9% is in about customer and patient services. That is your call center, scheduling, those types of things. 11% is what we call administrative clinical support functions. This is your nursing admin. This is case management, people in administrative roles, helping people navigate the system that way. 14% is in industry-specific operational functions. That's your underwriting, credentialing, enrollment, things that are specific to healthcare that we need in order to make the healthcare system work. And then 39% is frankly in industry agnostic corporate functions. Every organization in this country needs HR, needs finance, needs IT. And those things are not unique to healthcare. And so we categorize those separately. And then we looked at how does this break up by stakeholder group. And what was interesting here for us is the amount hospitals and physician groups spend on things that are industry agnostic, things that are not special to healthcare. HR, finance. And part of the issue, or part of the reason this number is so high, is there are 2,500-ish health systems in the United States, 6,000 hospitals. And when you actually get past the top 100 or so hospitals, there is a very long tail. And for them to have the resources to get resume screening that everyone talks about and accounts payable systems, it is really hard when you don't have the same infrastructure and scale. And that's why you see that dark blue there, the 46 and 44%, take up such a large portion of what hospitals and physician groups spend. On the private payer side, you see a lot more spent on the industry-specific operational functions, and we'll talk about this in a moment. This is your prior authorization. This is your claims processing, things specific to healthcare that we ask private payers to do given the way we have structured our healthcare system. But then the question comes, all right, we spend $950 billion. How much should we be spending? And one thing David Cutler and I don't love about the literature is it says, okay, if we were Canada, how much would we spend? But we are not Canada. We have not chosen at this time in this country to be a single payer system like the UK. We have chosen something different. So instead what we did is we said, let's go bottom up. Let's start from the bottom. What are different interventions we know that are not scaled across the US healthcare system by stakeholder group? How much could be saved? And what we found is of that $950 billion, $265 billion could be saved as true run rate net savings. So what I mean by that is it's not saying, oh, you implement this, it'll reduce your costs by 3%. Sorry, I forgot to tell you it costs 2% to actually implement it. Nope, this is net savings, so this accounts for the incremental OpEx you have to put in. It does not account for the one-time cost, so there are investments you have to make. They'd be roughly 1 to 1.5x of this, but this would be true run rate savings over time of $265 billion. You might ask, where does this $265 billion come from? So we found 30 actionable interventions. I'll just skip ahead to the list here for a sec. Oh, I didn't copy that slide in. But the way we broke it is into these 3 buckets, which is quite important. We said, what is a within intervention? What is something that I am an organization, hospital X, private payer Y, I can do by myself with what's available to me today? $175 billion of that is just, you could call it the choice. An organization has a choice to make that investment, and they have not done that yet. $35 billion of that is what we call between. That is that a private payer in a local market and a hospital have to come together and decide we want to make prior authorization simpler by doing gold cards. You actually need a party on the other side to do it, but you don't need regulatory change in order to implement it. $55 billion of it was what we called seismic or industry level. These are things that we actually need to change at a regulatory, federal, state government level in order to capture these dollars. There's some overlap between the $55 billion and some of the other stuff. The $55 billion could actually be $105 billion, all the way up to that, and reduce the numbers above it in the within between if you did certain changes. But this is how you add up to $265 billion. And the interventions are known. There are 30 things that if you did in that within and between bucket, that would capture the dollars listed there of 210-ish billion. Where does it come from? On the left-hand side, you'll see it is spread out across everyone. Hospitals, physician groups, private payers. There are billions of dollars in each of those stakeholder groups to come and capture those dollars out. What is interesting is on the right-hand side, what part of administrative spending does it come out of? A lot of it's in the industry agnostic corporate functions, which just comes back to why are we spending so much on HR? Why are we spending so much on finance? A fact from some of our research is over 15 years, the healthcare delivery system created 10% of the GDP growth in the country and 30% of the workforce growth in the country. So then you ask yourself, why do we have a labor productivity problem? Well, when you're plowing more people in to go and capture those dollars, inherently 10 and 30, there's your ratio, you're not gonna have labor productivity gains. This is why some of this stuff doesn't happen on the industry agnostic side. My purview at McKinsey and with my fellow partners, we've done a lot of work with organizations, and we find there are 4 general themes of what has to be done. First is the organization just needs to make a choice that this is what we want to do, strategic priority, committing to the change. What's really cool and interesting, and we're going to talk about it later today with AI, there is a broader partnership ecosystem. There are vendors out there now that have lowered the cost to do this. You don't have to build your own HR resume screening system. You can go and vend it. And then you have to allocate the resources. Last thing I'm going to do for a moment is just hit on where does the industry level change come from as you think about the state of California, you think about the federal level. It would really affect a lot more of the financial transactions, claims processing, billing, and also the industry specific. Could we make credentialing for providers easier as we think about just how many different provider directories there are and how people have different addresses in each one? And it's just crazy. These are just some of the things we wrote up. But what I want to hit here is I was a fellow with Clay Christensen, and he spent a lot of time thinking about how do you make action? How do you make innovative change happen? And what we find in healthcare is we have a lot of the ability to innovate, as he would say, that we kind of know what we need to do. We say site of care change. We don't have the motivation to do it. Our system, the way our system is set up today, does not incentivize people to do some of these seismic changes and to therefore create the motivation. There is no feedback loop. There is no incentive for product design. There are no budget constraints for end users. These 5 things on the top are what Clay had laid out as the things required for disruptive innovation. So it's not just about what we're going to do at the industry level. It is about how do we make sure that everyone acts within that to execute the change that we want. So I'm going to pause there and hand it over to the last speaker.
Hi there. Welcome. Thank you for coming a little early. It's going to be a few minutes before it's time, so could you just fill out this form here? It's basically the same information you filled out when you registered, but I just need it again. And can I also get a copy of your ID card, please? It sounds like you have no idea what I'm talking about, so I'm sorry for that. Let me just take a step back, tell you a little bit about my organization, because many of you likely remember the CareMore name and wondered what happened to us. But after several years of being passed around among a few health plans and several name changes, as of last year, CareMore is once again an independent, delegated, full-risk provider organization, and now is part of Mosaic Health, along with the Pre-Health and Millennium Physician Group. And as such, we enjoy the regulatory fun of being a provider and a payer, and that's the lens that I'm going to use to approach this topic today. So let me get back to the original scenario. You're my patient, and I'm your new PCP. You recently saw a specialist, you're admitted to the hospital, and I don't have your records. So if I want to get them, I need to have you fill out these somewhat complicated forms, and then I fax it over to the other providers. Are there any other organizations that are still using faxes? And then a few weeks from now, I'll get back a stack of papers by fax that are formatted in a way that takes 4 pages of useful information and turns it into 200 pages of mostly useless, generally redundant garbage that was designed to be reviewed on the other EMR and not as printed output. And so then I get to dig through all of that, try to identify the key elements I need to know, and then I get to document them into my system. Although there are a couple of dominant EMRs used in the hospital space, on the ambulatory side, there are more than 800 different EMRs in broad use, and of course, almost none of them talk to each other. So to try to address that problem, there have been efforts to implement these health information exchanges, or HIEs, like Manifest MedX here in California. On the surface, this is just an attempt at a workaround for the real problem. However, even this record is incomplete and formatting can be unwieldy. As of now, relying on this type of HIE can actually add to the administrative burden by giving the illusion of containing pertinent medical records, but resulting in a partial record with more redundant information that needs to be sorted through to try and extract the key elements. Some people think AI might fix this, but we're not there yet. I dream about a centralized medical record for everyone, kind of like your personal healthcare Wikipedia page that gets updated and refined for accuracy over time and could be relied on as a source of truth, but I don't see that happening anytime soon. All right, so now it's time to renew your meds. The good news is you've been stable and doing great on those medications for years, but it's the start of the year, or maybe you've got new insurance. Either way, neither you nor I have any way of, or any easy way to tell which of your meds are no longer on your formulary or how it's going to affect your copay. Like Kolschmidt-Nick. He'd been stable on Advair, a combination of a steroid inhaler and long-acting inhaled medication for his asthma for years. He'd plunk down at $67 every 3 months for his inhalers, go on his way, until January of 2024 when his pharmacy benefit manager, or PBM, they made a formulary change and his pharmacy asked for $539.19, which he didn't have. So he didn't get his inhaler and he died that same month from an asthma attack. I bring this up to point out that administrative waste doesn't just have a financial cost, but also can directly impact our patients. So another possibility is that you're subject to step therapy, where I need to prove to the health plan that you've already tried other drugs on their list and they didn't work. Sometimes those drugs actually are more costly than the one that works, but the PBM gets a bigger rebate from the drug manufacturer, so those are the ones that are preferred. Physicians report completing about 20 to 30 prescription drug prior authorizations per week on average, which is around half of all of the prior authorization submissions they need to make. Somewhere around 1 in 5 prescriptions now require a prior authorization on average, and each one of those takes 10 to 20 minutes of staff time, with the need for a physician to be involved about a third of the time. Large enough practices have to hire additional staff just to help with prior authorization management. So as long as I'm on the subject of PBMs and administrative waste, I have to mention these GPOs. I only recently became aware of these, so maybe you're already aware of them, but I'm assuming some people have not. So as you know, theoretically, the pharmacy benefit managers, or PBMs, are supposed to negotiate the best drug prices for the best drugs so that the health plan can have the most cost-effective formularies for their payers. Some of those discounts are in the form of rebates, so that the price may still be high, but on the back end, the drug manufacturers give a rebate to the PBM, which siphons off some fees and then returns the remaining dollars to the plan to offset other costs. Of course, the higher the cost of the drug, the higher the cost of the rebate, and the higher the amount of the fee that the PBM was keeping. So this came under scrutiny a few years ago, and now I've been hearing about these PBMs saying that they're going to start funneling 100% of those rebate dollars back to the health plans, and I thought, well, that sounds really good, until I found out that a few years ago, the 3 major PBMs established what they called group purchasing organizations to sit between themselves and the drug manufacturers. The thing is, these companies don't negotiate on behalf of a group of PBMs. They only do this for one, or in one case, 2 PBMs. And they subcontract the jobs to do the negotiating work from the PBMs themselves. But now, because they're inserted between the drug manufacturer and the PBM, they can continue to collect those fees, and the PBMs can pretend that they're giving 100% of those rebates back to the health plan. So in a 2024 report, the FTC estimated that those entities pulled in about $7.6 billion in fees in 2022 alone. So back to you as my patient. I want to make sure you're getting the best care, and of course, my organization is being measured on the quality of care that we provide. But the problem is that defining and measuring quality is really complicated on its own, and yet it's made even more confusing by the number of metrics being measured. There are measures for stars in MA, and other measures for commercial HMO, and other measures for this Medicare ACO, and more measures for that Medicare ACO. And this is a big deal because the scores on those measures impact payment. And Medicare's approach on stars has not been to set specific thresholds for quality, but to cluster results in this survivor-style competition. And so over time, the distribution of performance has become so narrow on some of these measures that you need resources just to track them all. For example, for medication adherence, which is a triple-weighted measure, the cut point for 3 stars is 89%, and for 5 stars, 91%. Think about the labor expense, patient abrasion, potential medication waste, as all of the providing groups are trying to get those last handful of patients to pick up that prescription as we get closer to the end of the year. And how much of the impact on those results actually comes from the demographics of the population and isn't a representation of the hard work the providers are doing? We certainly struggle with our homeless population picking up their prescriptions. After you've had your visit, I have to write my note. You're a Medicare Advantage patient, so in December, you look like this, and in January, you look like that. Your dialysis, COPD, diabetes, stroke residuals, prosthesis, heart failure, metastatic cancer, they've all suddenly disappeared. And they won't reappear until I code for each one of them in the precise fashion required by CMS. Ensuring that all of those conditions are conveyed to CMS in such a way that they're fully captured is so complicated and so important that I need to have additional staff just to help to remind me not to forget anything and to ensure that I submitted the right combinations of codes. The functional way that they need to be listed so that they are clearly identified and connected for Medicare to capture them is not based on the way that a clinician would normally combine diagnoses naturally in their note. So this adds to my note bloat and the size of what I write. So of course, I also have to have staff for making sure that my billing codes, my place of service codes, my modifiers are all correct, or I'm not going to get paid. This report came out just a few days ago from Massachusetts. Around 1 in every 5 claims in 2024 that were submitted by providers to fully insured health insurers were denied. Only 1% of those denials was because of medical necessity. Those denials and subsequent appeals and resubmissions, those require even more staff. So over the past few years, many of these plans have implemented these AI tools to scan through and then deny the submissions based on technical grounds. And then more recently, provider groups have implemented similar AI tools to respond and then resubmit. So we have these bots arguing with the bots, and maybe that's progress. The last thing I'll touch on is the documentation requirements we inherited as being a delegated provider. I spoke to a colleague that noted that her organization has over 70 health plan compliance templates that need to be continually updated and fixed because these templates change much more frequently than you would think. And that takes extra staff to prepare for and then address multiple audits. For us, as a group that manages a lot of special needs plan patients, each of them requires an annual health assessment and an individualized care plan. These are highly regulated and formatted documents that often end up being perfunctory. The initial idea might have been good, but in practice, it ends up being a time-consuming check-the-box process that has no real impact on patient outcomes. We are the providers taking direct care of these patients, and we're also financially at risk for their outcomes. And yet these requirements demand us to adhere to specific processes when ultimately we're focused on taking the best care of our patients because their outcomes don't just impact them, they impact us. So I'm limited by time, so these are just a few examples. Each one requires additional resources to deal with systemic frictions that don't directly improve patient outcomes. What makes this especially strange for those of us in delegated at full risk models is that we're already financially accountable for the outcomes. If our patients are hospitalized unnecessarily, we pay for it. If their chronic conditions spiral, we absorb it. Our incentives are aligned with doing the right thing, and yet the administrative structure requires us to add process on top of process and people on top of people just to comply with the regulations. The more accountability we take on, the more documentation, verification, and compliance infrastructure we inherit. That's the paradox. And so that old clipboard never really goes away, it just gets bigger. Thank you.
So who's excited about a career in medicine after that? Okay, we actually have a good amount of time for questions, so I've got a couple that I'll get started with, but I would encourage you all to start thinking about your own because we'll certainly have time to take a few. Yeah, I mean, who is excited about a career in medicine after that? So I listened particularly to that last presentation and just thought, if I needed illustrative evidence of my claim that healthcare is too complicated, you just provided it for me in like 16 different ways, right? So all of this complexity didn't happen by accident, right? We didn't just wake up one morning and there were GMOs, right, on top of PBMs, or there were 16 different ways to fax things, or 400 different metrics. So it emerged from a system where everybody, different actors in different parts of the system had reasons to build it that way. And I'm just curious, each of your perspectives on who's benefiting from keeping it this complicated, and what would it take to help people make different choices? Take it away.
I mean, I can start. I don't think this is like there's some cabal sitting up somewhere trying to make the system complicated. I think there's this inherent issue with healthcare that people can't afford to pay out of pocket for an extreme medical emergency, and that's how the health insurance system emerged. And since then, we've been dealing with sort of how to kludge together some kind of way to pay for care, and it has become complicated, and then we're putting Band-Aids on something that's already complicated, and it's getting more and more complicated and messy. I mean, from my perspective, if I look at what has actually worked in terms of reducing spending, and I think waste is an important component of spending, I mean, there have been two things that I have seen really at the state level that have seemed to show promise. One is reference pricing approaches, and another is more of a price setting, or like restricting price. And I don't mean the sort of spending growth targets that states have implemented. I mean things like the Rhode Island affordability standards, where there is a amount that prices can increase in a given year, or Maryland total cost of care, or something like that. And those approaches kind of force somebody to do something about it, right? Like, we don't know exactly what is going to happen because the system is so complicated, but I don't see too much promise in trying to untangle this individually, or trying to, from a policy perspective, where you're 50,000 feet above the problem, trying to untangle it. I think we need to create the right incentives in the system.
Can you just clarify before we move on why you think spending growth targets wouldn't serve the same purpose?
Well, so that's a good question. I think it's because in most implementations, they have no bite. They have no bite. I think California is the newest of the spending growth target states, and it does have some things that it can do to enforce those spending growth targets. Time will tell whether or not how it works out. We know Massachusetts did too, and they have very, very rarely done any enforcement. So time will tell, but I think that's the issue.
I mean, I just, part of the problem, I think, goes back to the essential tenets of the Americans, right? Where it's a capitalist society and it's an individualistic society. And in healthcare, the incentives are around, how do I make more money? How do I make more money? What do I produce that can cover a niche or get more revenue in some manner? And now in addition, you've got this internal freedom that people should be able to choose and do whatever they want, and they're welcome to make bad choices. They shouldn't have to listen to anyone to guide them. And I think that has really brought about the infrastructure that we have, where the spending is excessive. It's being used on medical care that's been shown not to be beneficial, and it's been and trying to regulate that down and figure out how do we identify and manage populations. It's very different to manage a population than to deal with an individual's health needs. So I think those two things conflict, and I think that's a big part of why we're struggling so much with improving this problem.
Yeah, I might just add 2 points. I think what you said is spot on. I don't think the U.S. healthcare system is set up to be a social good for the country. Yeah. I think it is set up to think about innovation, if I put a positive spin on what you said. And there's a study that came out that showed when statins came out and they moved to generics, Medicare beneficiaries saw a slower rate of spending growth from 2005 to 2019. Half of that slowdown was due to statins reducing cardiovascular events, diabetes, other types of things. Well, we paid for that for 15 years until those drugs went generic, and then we saw the benefits of it. And I think that is the way we've asked our system to be. So unless we want to fundamentally change the purpose of healthcare in the US, it's hard. The second thing I would say is We do a great job of pointing fingers at each other too amongst the stakeholders. So, you were sharing the formulary example. Well, let's take UC Irvine, for example. Who actually sets the formulary for everyone at UC Irvine? It is when UC Irvine puts out an RFP asking a PBM to bid on their contract that they say, these are the drugs and these are the costs we want to manage for. UC Irvine sets its formulary. The PBMs execute that formulary. So you can look at that article and say, oh, Optum RX, they increased it, so on. If that was, I don't know that story, but if he was an employee and the employer changed the formulary, that's actually the employer that made it $500. It's not Optum RX that did. And it's very easy to say, oh, it's Optum RX because that's what I see on my card. Oh, it's Cigna that's denying me this. But it's a lot of time in an employer-sponsored insurance system. It's the employers that are making the choice of what to and what not to cover. But we don't know that. We don't think about it that way. It's if I take an Uber and go to McDonald's, that's not Uber's fault when my wife yells at me for eating McDonald's. That's my fault because I chose Uber to McDonald's. So.
I hear that, and I would argue for the patient's perspective, it doesn't matter. It doesn't matter if it was Optum or his employer, right? I mean, ultimately,
someone made the choice for the formulary to be that way,
they did.
And that's UC Irvine is trying to manage its costs.
I actually have a follow-up, and I'm going to direct this one to Nikhil first, but I would encourage others to weigh in. I walked into this conversation thinking that I was going to ask folks, that $900 billion figure, it's cited all over the place. And I came in thinking I was going to ask you how we figure out what is essential administration from waste. And you actually answered the question. And so what it sparked for me was the number that you gave, the $265 billion that we know is avoidable or wasteful administrative spending. There's a portion of that you defined as being kind of within interventions. And one of the challenges that I think we often see, as Adam just alluded to, is where the incentives sit. Where the natural incentives for people to do things in a capitalist society. I would have thought intuitively that there was a natural incentive to reduce the amount of administrative waste that is amenable to within interventions, because that leads to a bigger bottom line. And so I'm curious why that's not happening. Why is that part of the problem intractable?
Yeah, maybe I'll tackle the hospital part of it first, right? So, we all talk about HCA, Tenet, for-profits. Well, for-profit healthcare systems represent a very small portion in the United States. We're mostly a not-for-profit health system, academic medical centers. What I want to do is I want to focus on critical access hospitals. They get paid on a cost plus, right? So what's their cost plus a little bit? And that's the way we structured it. Well, they're the ones that really have very high administrative costs on HR, finance. That's that long tail that they don't have the scale to go build the option that maybe Mount Sinai or Mass General Brigham, as I think about my area, does. But on the flip side, they have zero incentive, right? They're a cost plus system. This is my cost plus a little bit. That's when we get paid. And so if we have created that payment mechanism for those types of hospitals that are absolutely necessary in our country, you're going to continue to see that. And so a lot of what we were seeing in that 265, the 175 that's within, it's not the big players that we all think about. It is not going to be your HCA tenants with the for-profits. It's not going to be your Intermountains or Geisingers that have scale. It is going to be that long tail that just don't have the same access to resources, both on the private payer side and on the hospital and physician group side.
Other thoughts on that? I mean, there's nothing more frustrating than a problem that we know how to solve and it isn't moving, right? Any thoughts on why or what it would take to move it? Uh-oh.
I'm processing the whole thought of that long tail because it makes complete sense. And then I think about there are several structures in our healthcare system that just cost plus. There are FQHCs, we've got 10, 11 oncology centers in the United States that are all cost plus. And where are the incentives for the efficiencies there?
Any thoughts?
I mean, I think I'll just go back to the point that I made earlier, which is that, I feel like trying to address it on a point-by-point basis is not going to be feasible because it's too difficult for even the systems to figure out exactly how they would go about eliminating that waste, and that they need to have the incentive right in front of them.
Okay. All right. Because I think we have to talk about some solutions, and I can see some hands. Look, standardization, automation, regulation. We've touched on all of them. They're all on the table. I'd love just to know from each of you, what is one change, a policy, a technology, something contractual that could really make a difference? And specifically, what role could AI play? It's filtered its way through the day. It's the next panel coming, and it feels particularly relevant in this conversation.
Yeah, I mean, I'll start because I think it goes back to really where I started my presentation, and this disjointed medical record that you've got little tiny pieces all over the place. And that contributes in so many different ways to waste and poorer outcomes for people through communication, identifying information, having inaccurate information, repeated testing. And if we had a way of having a centralized, accurate medical record and AI being able to extract that information so there is something reliable, within an EMR, AI is starting to be able to place the information into the correct spots in the chart and surface information that you need to know. And it's being used for some of the problems that I addressed earlier in the talk. But if I could wave a magic wand and have something, then I think that would be it.
Yeah, I mean, I think that AI holds so much promise. Another use case is that takes that all off the provider to have to do all that documentation and write everything down or whatever. The AI can just sort of synthesize and provide this medical record and then transfer it across. So you have a seamless communication across. The interoperability thing is basically solved. What I find interesting, though, is that, your point about the upcoding, that AI is now being used to upcode. So it seems like the solution is also creating a problem. So I think that's really interesting to think about what other challenges might be introduced by this technology that, it's going to bring some good, but what else will it bring?
I think one thing I think a lot about is how do you enable AI to be successful? So I'll just give this example. I was looking through some prior auth forms, sadly, for somewhat fun.
For fun.
And, everyone will claim, let's say you needed a knee replacement. And one of the questions that almost everyone asks across the private payers, you can just download this stuff. It's all on the internet. I'm going to stay in commercial world for a sec. Have you smoked? Are you a smoker? Right. That's smoking. Sorry. Let me start there. Smoking is a criteria they look at. Okay. Same-ish isn't the same as exactly the same. So what happens is if you go into one private payers, they will say, have you smoked any time in the last 2 years? And another payer will ask, have you been a chronic smoker? So we might think, oh, we're asking the same question. But now think about it from the provider's perspective. I don't know that patient has United at that moment and that they're going to ask the last 2 years. So I asked, have you smoked in the last year? And then they say, no. Okay, now I go fill out the prior auth form and it said, did you smoke in the last 2 years? Now I got to go back to the patient, get that information, and come back. So AI can pull all that information out of the EMR, but what we don't have is good standardization of things that actually are not competitive advantages. Asking that question different is not a competitive advantage, but we don't have mechanisms, industry type forums, where we could say, look, we're just going to standardize it. The evidence shows that all that matters, I'm making this up, it's not clinically based, but smoking in the last 2 years. It doesn't matter if you were smoking before that, that's where the risk factor is. Everyone, you ask the question, MMDD, why, what year, what's the last year? Just standardize the data element. And now all of your AI tools can feed into that and send it back and forth. But that's where I would go. I would think about what are different things that if we just underlying fixed would enable us to do the AI stuff and use AI in a more productive way.
And in your view, that kind of standardization, which by the way, I think you could apply the same thinking to the metrics problem, right? The fact that everybody has a slightly different metric or a slightly different definition for, for procedures for prior authorization. There's a lot of things that we could standardize. Is that, how do you solve that? Is that a regulatory solution or is there an industry solution there?
I think I'll say it has to be industry level, whether it's an association that comes together, whether it's the state government that manned federal, but you can't ask I'm just going to keep you like Anthem, Blue Cross California, Blue Shield California, and Aetna to have the exact same, because then the DOJ is going to be like, why are the two of you talking? So the two of them can't go and say, oh, we're going to standardize our fields because the government's going to come in on them. So you have to create an industry connection point that is safe for them, and also validate that this is not competitive collusion. This is actually something that is not competitive. Benefit design, formulary design, those things can be differentiators, and you're not asking to standardize those. You're saying if you choose to prior auth knees and one of your 10 criteria is smoking, everyone has to ask the question this way. And if you're a doctor, you no longer have to check, is the patient Humana or Aetna or this? It's, oh, it's smoking, it's a knee thing. This is how I asked the question, and everyone signed up for it.
Okay. All right, I have a couple more, but I'd love to open this up because I see many hands. So is there a roving mic somewhere? Okay. The first one I saw was actually over on that side. So do you want to?
So, Adam, I was a little depressed by your talk because I used to run a fully designated group with 150,000 capitated lives 20 years ago, and I thought by now that would be it. They gave you the money and got out of the way. But just in your thoughts, think about Kaiser. Kaiser has one health plan, one medical record. No, I'm not a Kaiser person, okay, but one medical record, one payer. Is the hope that that system would be much less administrative burden and have a chance to be more efficient, and if everything was like Kaiser, that all these things would go away?
So when we did our research, we presented it Congress, White House, a few different places. We got asked this question: Intermountain, Kaiser, Geisinger, take your IDNs. They got to have lower admin costs than everyone else. So if you take a normal hospital, let's call it $100 are spent on admin, it is absolutely true that IDNs spend about $70 relative to that. But then what everyone will tell you is, sadly, I have to add about $30 back in on new functions to manage my system. So if you actually say admin spending holistically, and this is why we broke it down the way we did, it stays roughly flat whether you're an IDN or a hospital. The way you allocate it changes. Now, there's a new paper that I think just came out. I saw the title, I haven't read it yet, on do IDNs actually spend less on admin? So for the exact same dollars hospital, yes, it's about 30 to 40% less, but total admin expenses actually stay the same because you just have to put in different mechanisms to manage the hospital.
Then we're doomed. Capitalism will always win out.
But that doesn't mean that 265 over 950, the 28%, doesn't apply. There is more money Kaiser or Intermountain or Geisinger could get out too from their administrative spending that is still sitting out there. There is still avoidable or wasteful, whatever you want to call it. But it isn't the answer, oh, we should all switch to IDNs, right? That I just want to frame that as, yeah.
I'm so glad that I brought the panel of doom. Okay, I see the next one up here, and then one up there, and then I see.
Thank you, Dr. Solomon. I love the wiki EMR. So yes. I think we'll work on that. My question is really about the regulatory, and I think you're right in terms of administrative cost. What we call administrative theater. Moving numbers, checking boxes, things that are non-productive. I mean, I think we do that for a reason, which is regulatory. Given the fact that we're heading toward a financial cliff, do you think the regulators have the will to change the regulation so that we don't have to do these silly check the box and quality metrics that we know we do well anyways? What's the point of having 10 people to check over quality boxes and just take care of the patient?
I mean, I look at those regulations sort of similar to the coffee cups that says, be careful, contents is hot, that there's if we don't have any regulation, then people are going to go off and do whatever they want to do. And I think that was I really believe a lot of these regulations had very good intent as they came along, but it is applied to the minority. It's to protect against those outlier problems as opposed to that centralized thing. I think we were talking about the AI causing node escalation and billing. So in an organization like mine, I don't really care what my providers code or bill. They're going to get paid. They're getting paid the same. They're either capitated as a PCP or they're one of our employed physicians. They can bill a 5, they can bill a 3. It doesn't really make a difference. The outcomes what matter to us internally, and their incentives are going to be around their performance on keeping our patients healthy. And it does go back to those quality metrics. It does go back to their documentation on how they're addressing their conditions. That's in alignment, but there still needs to be some sort of regulatory structure to be able to have those comparisons between groups, between organizations. There is a certain amount of complexity that is going to be just inherent in the fact that healthcare deals with people and every person is a little bit different.
I might just add 2 thoughts, right? One is I think what you said about regulation is really important. One is usually lowest common denominator. We think about prior auths the same way. Sadly, we are solving actually for that. My good friend is an oncologist. He's like, why do I get so many prior auths? We're not solving for my friend who's well-intentioned and good. We're solving for that story you see in the Wall Street Journal about that one doc who was doing crazy stuff. And that's actually an unfortunate setup of our system. It's lowest common denominator, and therefore regulations do that. And 2, they focus on niche problems. Like we talk about the billing cost to process a claim. It's about $20, $30 in this country. 90% of those are $4 to $5. 10% are super high complex one, again, the ones we see in the New York Times and so on. And we're writing regulation to solve those. But if you take cents off the dollar of all those 90%, you get a ton of savings in the system. That's that fragmented tail of the hospitals that don't have access to process those 90% really fast, private payers who are smaller, don't have, we don't solve the majority. We look at these little niche things over here and we go and focus and we miss the forest from the trees, or the trees from the forest. I never get that one right.
I mean, we know CMS is considering, changing the MA star ratings right now. So there is will, and we've seen them change the risk adjustment approach even fairly recently to try to improve it, to try to make it better. I think the challenge is, will that actually work? I don't see a world where we just don't measure that at all.
Okay, there's the next one was up here. Yeah, there's one over there, and I've got one down here. And then I've got one up there.
Thank you. I enjoy your conversations, and I have some confusion surrounding the AI's role. I mean, I'm a pharmacy faculty member doing healthcare AI research surrounding some best-selling drugs like GLP-1RA. So I'm curious, because GLP-1RA, you also go through the prior authorization. And I checked with the colleagues from our own California's medical. They told me, no worries, Sherry, there is always a human being there for you to check your claims in medical, right? So I'm curious because I asked them, how do you do that? How do your human do that? They tell me we have a formula, we have an algorithm there, so our human will follow the algorithm of the formula. So here is my confusion. The human makes mistakes too. What's the trade-off between human following the formula to determine, I should deny your health insurance claim, or I should approve your prior authorization, or AI can do a worse job compared to our human? Thank you.
Yeah, I mean, I think there was in the news just a year or so ago with one of the health plans got into trouble because they were using AI to review. And where AI was then and where AI is now and the rate that AI is improving, it may get to a point, but I think there's always going to be the expectation that there is a human making the decision and things aren't left to the AI to decide. A place that AI is being used in such a way is surfacing, I'll give you an example. So surfacing some of these diagnostic codes to say, does this patient have this? Have they had this? Have they had their preventative care? Have they this other care that they should get? The AI doesn't necessarily know. It sees things, puts it together, and suggests this might be true. Ultimately, though, it's the provider that has to look at that. And the value of the AI isn't this just the suggestion and the screening of a large volume of information, but it'll surface the original information so that somebody doesn't need to dig through the electronic record to try to find it and can just, oh, here it is immediately, I can look at this. And so it is a time saver, but ultimately it is still going to be human driven, and it cuts both ways. If you're going to make an error, you want to preferentially be somebody was looking at that and made the choice.
I would just put a positive spin on AI. My wife graduated from med school in 2012, residency in 2016. The amount of medical knowledge since she graduated in 2016, I think technically has quadrupled. So that means even if she learned every single thing the day she finished residency, she knows 25% of medical knowledge today. And so I think we talk about AI making decisions, but man, how much could AI help a doctor versus having to sit and then she can spend time with her kids, with me and other people at home instead of just constantly reading NEJM and saying, what's the latest thing? So there's a lot of other things that AI could be used for. I'm sure the panel's going to talk about it next.
Thank you. Appreciate that.
All right, I had one down here and then one up there.
Yeah, the first question for Dr. Solomon, and others can jump in, and disclaimer, I am a pediatrician, so be gentle. I've heard, I saw the definition of administrative costs, and obviously there's some subjectivity to that outside of MLR measurements and things like that.
That's a long story.
But what I haven't heard anybody talk to, which is surprising, is care model redesign and shifting the administrative costs to more effective administrative interventions, i.e. intervisit, calls, care management, social services, those types of things. And there is clear literature that shows that those interventions are beneficial. As we know, 80% of our health has nothing to do with doctors and hospitals, right? So I'm wondering your thoughts about care model design and the opportunity to shift how we pay for healthcare, advanced primary care, focusing on intervisit care, et cetera.
I mean, so that is exactly the way our organization operates, right? And when you look at the metrics on a well-managed group, their hospitalization rates and their other utilization metrics are better. The patients have better outcomes, which should retranslate into reduced expenses and more profit. But what I've seen in all the years that I've been working in this space is those organizations, all of those things that you just talked about, are more people, more time, and that is, you're basically replacing the extra utilization and medical services that patients are getting with care, whatever it may be, just frequent touches, outreach, social work, pharmacy, all these other team members that are helping to keep the patient healthy. You're spending the money there instead. Net, it's not as much of a profit as you would think, but the patients do get to experience better outcomes, better experience, it's better results. It reminds me, and I don't remember how it was a decade or two ago, Oregon had an experiment, right? They were expanding their Medicaid, the Oregon Health Plan population, and they ended up, instead of just, with the dollars that they had, they did a random assignment. So all these people were potentially eligible for the expansion, and they randomly picked people who were going to get the expansion, and they had those that didn't, and you had a natural experiment to see what happened. And it turned out that the people that did get into the Oregon Health Plan, they had better utilization, better outcomes, and were happier, but their costs weren't any less than those who didn't go into the health plan. So you can kind of, you're not getting necessarily seeing that kind of dollar savings, but on a patient level, it really does make a difference.
I would add that, I am, as an economist, right, I actually don't really care about whether we're spending money on administrative cost or whether it's healthcare. What I just want is the whole amount to be either lower or better value, right? And so if it's the case that a care management model and someone's doing something that gets billed as an administrative cost, if that leads to a total reduction in healthcare spending, or if it, as you're saying, improves outcomes and makes it a better bang for the buck that we invested, I think that's great. And we shouldn't be like slicing and dicing and saying, well, now it moved from 30% of administrative cost to 35%. If total cost fell or if patient got better, then I think that was well worth it.
Okay, I've got a gentleman who's been very patient at the front.
Thanks for this excellent panel. Adam, excellent job.
Thank you.
To tackle something this big and complicated, I think you need some big ideas. And my big idea is I'd love to eliminate faxes from healthcare.
Wow, it's 2026.
It's ironic, we're talking about AI and the bleeding edge of technology, and we still have, if you go to Hill Physicians Medical Group physician offices, they're inundated by faxes. They literally have to employ people to scan faxes into machines and then put those information into the EHR. Incredibly inefficient. So my question to the panel is, do you think eliminating faxes should be a priority? And if so, how should we tackle it as an industry?
Could I add beepers to that? My wife's beeper still goes off, and the fact that she has a beeper in 2026 to pager is ridiculous for healthcare.
After we eliminate beepers, how can we eliminate faxes?
You've stumped us.
Yeah, I mean, to me, it goes back to the medical record story, right? And I say we fax over those documents. It's electronic. It's the fax that comes back isn't really being printed out. It actually goes straight into the EMR. But it is still a fax. It's just an electronic fax. So one tiny baby step.
We hide the faxes. That's the. Okay, we have probably time for one, maybe two. So I can't actually see there because there's a spotlight situation.
Dr. Solomon addressed one issue, broader issue about health information portability. The way we manage it right now is that every hospital owns the health information, and for them to release it, we have to sign a letter from the patient that they can release it. What if we give that ownership to the patients? Every patient has a smartphone. If there is a portable version of their health information on their cell phone, so when they come to my office, I can scan it. There's a QR code. I can scan it. I get all that information. Of course, we need to use AI to sift through all that junk that we put in that, notes that you and I make, but maybe a clinical summary can be in that QR code that everyone can access. In my opinion, if it's my information, it's my data. I can share it with anyone who I want.
Yeah, and I mean, I had a similar thought, but using like blockchain technology, so it is yours, and you can decide and give permission to anybody you want to access that record, and then take it away whenever you want when you get the list. But you're singing my song. I'm a proponent of everyone having a centralized record that we know is accurate. Patients don't always love what's in their medical record, though, and so obviously they have an opportunity to put something in there if they disagree, but. I definitely am a supporter of giving the patient control of their record to be able to share and for them to have a centralized, accurate medical record. It would improve so much of this extra waste. And I think outside of just the sharing of records and the duplication of testing and all of that, some of the questions about quality, what are the outcomes, what are you treating, how are you doing? Again, that information theoretically could be extracted from some sort of centralized database if it was anonymized, so that we protect people's privacy. It would facilitate a lot of this information and make it more accurate on outcomes.
Okay, so we're at time. I think we've actually done a great job of teeing up our next panel on AI and technology. I want to ask you to join me in thanking our panelists for, I thought, a very provocative conversation.